Good morning, everybody, respected colleagues and faculty members. The topic given to me for today is impact of metabolic issues in patients with MASH on MASH recurrence following liver transplantation. We all know that recently there has been change in terminologies from NAFLD and NASH to MSLD and MASH to avoid the stigmas and to put a pathophysiology link in the nomenclature. So the words has been changed to MASLD and MASH. The MASLD is diagnosed recent ASLD guidelines that published in 2023. The MASLD is diagnosed when there is a more than 5% hepatic steatosis and the patient satisfies one of the cardiometabolic criteria, that is high BMI, the raised blood sugar levels, the hypertension, that is blood pressure more than 130/85, the dyslipidemia with triglyceride levels more than 150 milligram deciliter, and the low HDL levels. When the mast cell it progresses, that causes especially inflammation in the liver, leads to MASH, and it has a characteristic histopathological features diagnosed on histopathology, associated with hepatocyte ballooning and with lobular inflammation, and also with the microvesicular, that is a large droplet steatosis. The MASLD is common, and even in current our day-to-day practice, even in OPD, even our center, after alcohol, the MASLD is the second most common cause indication for the liver transplantation. Also, because of the epidemic, the global prevalence also is rising, approximately around 25 to 30%, and almost MASH occurs in 5% of the population. And it utilizes lots of resources from the healthcare system, and it can progress to cirrhosis, and it can lead to primary liver cancer. As contrast to alcoholic liver disease, there are the Dallas consensus, and we have the strict listing criteria, that is we need 6 months of abstinence. In MASLD, there are no absolute contraindication, though BMI more than 40 is a relative contraindication, and also the high BMI is associated with post-op increased hospital stay, infective complications, graft dysfunction, but still because there is no restricted criteria for MASLD, it is a leading cause of liver transplantation worldwide. Why we know this problem? Because of the rising epidemic, the MASLD has been associated with increased excessive mortality as compared to the general population. This is the Swedish National Registry data. They have compared the NAFLD with the general population, and they have the NAFLD patients has been matched to the population comparators based on the age, sex, calendar year, and the country of residence. The cumulative mortality is quite higher and increases as the follow-up increases as compared to the general population, and the mortality is higher across all stages of the MASLD, and also it increases progressively as the stage of the disease progresses from the MAFLD to the advanced fibrosis to the cirrhosis. Now, similar to sarcopenia, the MAFLD or MASH, it goes from the pre-transplant to the post-transplant. Especially typical in Indian scenario, we advise the patient initially 3 months to take more as the sarcopenia is there, and the catabolic process of the cirrhosis reverses because they eat more, especially the high calorie diet. So this problem again comes after post-transplant setting. So basically the recurrent and de novo MASH, the difference is based on the clinical only. There is no histopathological features which can differentiate between the recurrent and de novo MASH. The diagnosis depends on the pre-existing disease, that is presence of the MAFLD or MASH prior to the transplant, or presence of the signs of the metabolic syndrome prior to the transplant. So what is the prevalence of the disease? The recent meta-analysis published in the Transplantation in May 2025. They have analyzed 28 studies, and they have reported the recurrent MASLD in almost 35 to 50% of the patient, and the MASH was diagnosed histologically in almost 11 to 24% of the patients. But there was lots of heterogeneity among the studies because there was no consensus for the diagnostic criteria for the MASLD or MASH. As compared to the de novo MASH, when the patient has been transplanted, the indication other than the MAFLD related cirrhosis, usually the pathophysiology is different because the Here the immunosuppressions play a major role, leading to metabolic derangement and causing MAFLD. And so the prevalence is lower than the recurrent MASH, and the reported prevalence is 18 to 40%, and the MASH has been diagnosed histologically up to 20% of the patients. So as I told, in basically in the recurrent MASH, almost 80 to 90% of the patients, because they usually have pre-existing comorbidities like part of the metabolic syndrome, that is diabetes, obesity, hyperlipidemia, and immunosuppression in the post-transplant setting worsens these conditions, leading to recurrence. So they usually have a higher recurrence as compared to the de novo MASH. Otherwise, de novo MASH, the immunosuppression leads to metabolic derangements, and the side effects of immunosuppression causes diabetes, increased weight gain, and hyperlipidemia that leads to de novo NASH. At see the natural history, we all know if you take from the normal liver to the cirrhosis, it takes almost 3 to 4 decades to leads to from obesity, dyslipidemia, and the cirrhosis. But now the recently we are changing, even you are seeing the change in this pattern. Even you are seeing the earliest, even at younger age, we are seeing the NAFLD related cirrhosis. Especially in de novo NASH, this process post-transplant setting, it still takes 10 to 20 years to develop in graft from the dyslipidemia, obesity to the causing advanced fibrosis and cirrhosis. In contrast, patients who had a pre-transplant had a MASH-related cirrhosis, they underwent transplant for the MASH-related cirrhosis. In that, the disease progression occurs in the fraction of the time, and they usually develop advanced fibrosis and cirrhosis quite rapidly within 5 to 10 years. So now come to how to diagnose post-LT MASH. As pre-transplant setting, very easy, but in post-transplant setting, both in DDLT and LDLT, it is quite difficult to correctly diagnose the post-LT MASLD or MASH, because in a DDLT scenario, though it is a whole graft, both the inflammation because of the IR injury and the regeneration happens within the same liver. And in LDLT scenarios, basically it is a partial graft, hypertrophies because of the acute rejection, inflammation episodes goes on simultaneously. So there are basic tests like liver enzymes, they are available very low cost, but still liver enzymes still in day-to-day practice, especially the patient has ringling transaminitis and the MRCP is normal and associated with the raised SAP and GGT, and there is no CMV, you should suspect, and they have associated the signs of metabolic syndrome, you should suspect that patient is having immunosuppression related MAFLD or MASH. We have imaging, we have ultrasound. Basically ultrasound is more useful in diagnosing advanced fibrosis, and but it is subjective, but it has a variable ultrasound interpretation. The CT and MR is more now preferred in post-transplant setting, especially the proton density fat fraction. It has reported more than 90% sensitivity and specificity for diagnosing both MAFLD and fibrosis, but still it can miss the early fibrosis, and even it is preferred in LDLT scenarios. The biomarkers based non-invasive markers, especially those are platelet based, FIB4 and APRI, because in post-transplant setting thrombocytopenia is common, so they are not yet reliable. And the other things, the fibrosugar, which are based on the hyaluronic acid based markers, they are not yet validated in post-transplant setting. The fibroscan is also not reliable because the inflammation and other rejection related also overestimates the LSM level, so it falsely overdiagnoses the post-NAFLD and NASH. The MR elastography is the issue is the availability and the cost, and the experts too, because it has different protocols to read, and also the most of the MR elastography based studies, they are SCV related cirrhosis. In other, they have limited data, we need more data. Biopsy though, especially in the DDLT scenarios, because it's a whole graft, the biopsy is the gold standard to diagnose post-transplant MASLD or MASH. But in LDLT, because of the partial graft, the risk of complications is very high. Also, even the findings of the fibrosis or the inflammation-related MASH may be heterogeneous in the graft, and it may have a sampling errors also. So we need to have more consensus on this. So come to the points, the comorbidities, which in the pre-transplant setting, it continues in the post-transplant also added effect of the immunosuppression. These are basically the modifiable risk factors, and we need to see their impact on the post-transplant outcome. Like similarly, the obesity I previously told, the high obesity associated with the poor graft function, increased risk of complication, especially infective complications, and increased hospital stay, increased resource utilization. Especially the obesity with combination of the diabetes mellitus has the worst outcome. And in the post-transplant, especially the weight gain happens rapidly, especially within 1 year, that with immunosuppression effect in increase the recurrence of the MASH and increase the other metabolic complications. So the preferred treatment modalities I will come later on discuss in detail. Next is the type 2 diabetes mellitus, and almost the MASH and MAFLD has been found up to 50 to 60% of the patients recurrence who had especially insulin-dependent diabetes mellitus pre-transplant. The other factors are the higher donor age, the more recipient age, and high BMIs. That also the diabetes also associated with increased infective complications, especially the fungal related complication, the graft dysfunction, increased risk of cardiovascular complications. The CKD also, because of MAFLD, the CKD also incidence is seen almost 40 to 60% of the patients, and because of rising epidemic, the indication for the combined liver transplant, combined liver and kidney transplant also are rising. The pre-op CKD is also a risk factor for the post-op CKD. The patients with MAFLD have also associated with increased risk of post-transplant renal dysfunction, and the acute AKI which happen post-transplant also is the risk factor for the post-transplant CKD. And the superadded effect is the immunosuppression, that is CNI-induced nephrotoxicity leads to increased risk of post-transplant renal failure. Others, the comorbidities, hypertension and the dyslipidemia. The hypertension mainly because of the CNI and the steroids, which leads to increased risk of graft dysfunction and the cardiovascular complication. The dyslipidemia leads to hepatic steatosis, inflammation, and systemic inflammation causes decreased graft dysfunction and the poor graft and patient survival. One of the important comorbidity we usually miss in the post-transplant setting, which can lead to weight gain and the dyslipidemia, is a hypothyroidism. All post-transplant patients should be screened for the hypothyroidism and should be corrected. Why it is important? If you see in the literature, the change in the BMI in the post-transplant setting usually happens initially first year, and basically this is the US data which has shown they follow the post-transplant MAFLD patients regularly at 30 days, 4 months, 1 year, 3 year, 5 years. If you see the BMI, the gain rapidly happens within first year, and the percent of the patients, almost 1/3 of the patients achieve the BMI more than 30 within first year. Why this is important? Because the recent US study, they have categorized these patients based on the BMI at 1 year in the normal, overweight and obese. If you see the outcomes, the patients who had obesity at the 1 year post-transplant, they have inferior long-term outcomes because of the increased risk of all-cause mortalities, especially the cardiovascular risk factors. The most important is the increased post-transplant mortality is mainly because of the cardiovascular events. If you see the cardiovascular incidence, almost within first almost 10 years, it goes up to the 40%. And usually the post-transplant MASLD associated with even the myocardial inflammation, they have atherogenic plaques in the vessels, and this causes endothelial dysfunction. And also the MSLD have, they have loss of QT prolongation. We see the findings because of associated cirrhotic cardiomyopathy. So especially the coronary events and the arrhythmias are common in post-transplant setting. One of the study from the US, they have compared the cardiovascular event at 1 year between the MASH and the alcohol. The MASH patient had almost threefold increased risk of cardiovascular event at 1 year after transplant. So most important, the metabolic derangement cause in post-transplant setting is immunosuppression. And we know the corticosteroid have important role. They increase the appetite, increase the insulin resistance, causes weight gain, causes hypertension and dyslipidemia. Usually the major driver of the recurrent or de novo MASLD. We as a transplant surgeon try to taper if the graft function is stable, liver tests are improving. We taper off as early as by 3 to 6 months, and we do regular glucose, lipid and blood pressure monitoring. Especially if the patients are quite diabetic and they have higher hypertension, we prefer steroid sparing regimens. Next is the CNI. As CNI knows, the tacrolimus causes direct beta cell toxicity, has increased the diabetogenic, and next is the cyclosporin, which has more causes dyslipidemia, leads to insulin resistance and increased post-transplant metabolic syndrome. So we, especially in LDLT scenario, as graft is partial, we try to keep initially target the TAC levels lower side, that it's 5 to 7. And the patients who have uncontrolled diabetics, we usually add the antimetabolites. So we have the CNI sparing effect. Instead of giving the one drug at high levels, we try to prefer the combination of the drugs at low dose levels, which have more safety. Next is mTOR inhibitors, because of his advantage of the renal sparing effect and renal protective. Lots of health professionals, they use mTORs in post-transplant setting, especially patients who have the renal dysfunction post-transplant setting. But mTORs are bad for the post-transplant MAFLD recurrence and the metabolic syndrome. Especially they cause more dyslipidemia. They don't have much effect on the weight, and the effect on the graft steatosis is not yet clear. So we need to have regular lipid monitoring, especially the patient have developed earlier signs of metabolic syndrome. We should stop the mTORs. Next is the antimetabolites are very weight neutral, and they don't have effects on the lipids or the insulin sensitivity. So they are very helpful in steroid and CNI sparing effect in post-transplant setting. So how to treat this patient in post-transplant setting? Usually what we do, because typically Indian family, they overfeed them, and initially 1 year they gain the weight rapidly, especially in first 6 months they gain more than 5 kg or 10 kg weight. So we try to treat them when they developed signs of metabolic syndrome. That is a conventional approach. But as I shown previously, usually the rapid weight gain happens, or the metabolic derangements happen initially in 3 to 6 months. So in every regular OPD visit, you should tell them that what is a healthy lifestyle, and especially dietary modifications and regular exercise, and with added benefits of the exercise, and you should do a regular counseling. So that preventive approach is better than the conventional approach to prevent to happen the MASLD or MASH recurrence. What are the lifestyle modifications? Because Indian diet is carbohydrate rich diet, so basically they overfeed and they get rapid weight gain. We have to tell them the shift to the Mediterranean diet, that is a low calorie diet and high protein diet, no crash diets. Try to have regular meals, avoid late night snacks. You take more the complex carbohydrate and 20 to 25% of the lean protein. More to have unsaturated, that is polyunsaturated and monounsaturated fat. Take use of the millets, brown rice, whole meat, and oats instead of the refined carbohydrates. Target protein intake approximately 1 or more than 1 gram per kg per day. Avoid the sweetened beverages, packaged foods, deep fried food, and prefer mustard or the groundnut oil or the olive oil based food. And strictly avoid alcohol, and if possible, if they tolerate 2 to 3 cups of coffee, there is little evidence that it might reduce the risk of in the liver and the fibrosis. Next important is the exercise advice. As health professionals, we try to neglect this, but we regularly, because Indian patients, we need to counsel them at every visit. So you have to have aerobic and resistant exercises, that is aerobic are treadmill, swimming, cycling, which has increased the insulin sensitivity. Try to achieve the target of 150 to 300 minutes per week. Resistance exercises are push-up. You can use a body weight, use of bands, which decreases the visceral fat, increases the muscle mass, and helps to combat the sarcopenia. And you have to do 2 to 3 sessions per week. And if required, you can do a high intensity interval training that alternate with high and low workouts that maximize the calorie burn and improve the cardiovascular fitness. 20 to 30 minute sessions, 2 to 3 sessions per week. Especially in post-transplant setting, which are overweight and which have advanced fibrosis, we usually start with a low intensity exercise, that is supervised physiotherapy, walking, stationary cycling. We regularly do in the wards also, and that improves the fatigue and tolerance and mobility. As a whole, you should usually this patient have obstructive sleep apnea, and you need to treat that with regular positive pressure ventilation when on the home-based PAP. Also, they have some psychological issues like depressive component. They have need a behavioral counseling also to avoid the excessive eating habits. Recently, the next is when especially the weight gain happens rapidly after 1 year, when the adipose tissue expansion occurs, the lifestyle modification exercises becomes less effective. Here the play come the newer metabolic pharmacotherapy. Recently, glucagon-like peptide 1 receptor antagonist has been in pre-transplant setting. It has shown lots of publications are there which are shown very effective. But post-transplant setting, there is no much data. Few case series are there. These two case series which are both published from the USA, and they have shown that within 1 year, the patient who have, that is GLP-1 receptor antagonist, that is semaglutides, they have shown the percentage weight loss was higher in the patient who received this GLP-1 receptor agonist. Also, the second study, it was also a small group of patients, and the weight loss occurred from the 92 kg to the 87 kg, and it was statistically significant. The similar study from the Stanford University has used the combination of the or either GLP-1 or sodium glucose transport inhibitors. Basically, this the sodium glucose transport, this helps in glycemic control by decreasing the renal tubular glucose absorption, and the GLP agonist, especially they reduce the appetite, also the delays the gastric emptying, so it have both increased the insulin sensitivity and control the dyslipidemia. And these drugs have basically, these patients, there were 37 group of post-transplant patients with age more than 60 and median BMI of 33. Most common indication for starting this medication was diabetes, and the assessment of post-transplant liver fat was done only in 10 patients. It was done with both pre and post-transplant biopsy, and MR findings were available in the only 10 patients. It has shown a 50% reduction in the allograft steatosis, but still we need more data on this. The next important drugs, that is a paroxysmal proliferator associated protein, that is agonist, receptor agonist, that is, this is a seraglutazar, is a dual, that is alpha and gamma. It has a more the alpha action as compared to the gamma action. And this was also studied in the almost 44 patients. It was given 2 milligrams subcutaneously weekly for 24 weeks. And they have assessed the post-transplant liver fat content by MRI proton density fat fraction. The median was the mean of the liver fat content reduced from the 10 to 8, and almost more than 50% of the patients who had more than 5% fat prior to the starting the drug showed improvement in the fat content. Also has anti-cholestatic effect. There's significant improvement in the ALP levels. Also the adiponectin, that is protective adipokine levels, were quite high in the patients who received these drugs, and there was no effect on the muscle fat infiltration and the fat-free muscle. The newer game changers in mast cell, which has been studied in the pre-transplant setting, and possibly they might be considered in the post-transplant setting, but we don't have enough data, is the dual, that is combination of the incretin analog, that is dual GLP and the glucose-dependent insulinotropic polypeptide agonist. We have one the tirzepatide and resmetirom, that is selective thyroid receptor beta agonist. Both has been, there has been publication in landmark publication in NEJM, and shown especially the tirzepatide has shown the mass resolution in 60% of the patient with reduction in fibrosis 50%, and the resmetirom has especially anti-fibrotic effect in advanced MASH who have associated with the fibrosis. Both drugs has been well tolerated, but they usually have GI symptoms, especially vomiting, and the resmetirom has to do with diarrhea. So we need to monitor whether their interaction with immunosuppression, we don't know, because the drug also cause delayed gastric emptying. So we need regular immunosuppression monitoring in this patient. And the FDA has approved resmetirom for especially the advanced fibrosis in the pre-transplant setting, and it can be a possible useful in the post-transplant setting. But still, these drugs we have there, they are, but still exercise remains the medicine for even the pre-transplant mast cell and post-transplant mast cell. Why? Because these drugs acts on the single pathways, and because exercise acts on the multiple pathways simultaneously. So that's why the exercise has this is very cheap and very initially. Especially with the repeated counseling, we can achieve the goals, and the regular exercise, because of the action on the multiple pathways, is important, is easy treatment modality, and pocket benefit for the, especially in this, can be useful in the post-transplant setting. But in the real world scenario, whether because we don't, in a day-to-day practice, we don't see whether patients be able to achieve these weekly goals. We don't put the time on that. So basically in the real, this is basically data from the pre-transplant setting, that the rates of the lifestyle advices from the lifestyle counseling and the exercise professional referrals are quite low, and in post-transplant setting might be the percentage may be lower. So if you want to make the real change in the, especially in the post-transplant population, we want to have health impact, I think we also start giving a exercise prescription form, so we can prescribe them the what to do aerobic exercises, what to do resistance training exercises, and whether they were able to achieve these goals or not in each visit we can check. Even we at ILBS also we can start such prescription forms. Now last is the role of metabolic interventions. This even the this role of like endoscopic surgeries and the bariatric, that is minimally invasive surgeries, the role is controversial. Most of the decompensated cirrhosis, they are not preferred. There is some evidence, especially in the US from the Mayo Clinic, there has been done a simultaneous transplant and sleeve gastrectomy has shown the excellent results. But the one study published in liver transplantation, especially the UK group, that is Italian group, they have shown a certain high morbidity and the mortality. The 90-day survival was only 60%. Especially why it was high, because this increased morbidity and mortality because of especially higher in, if the patient's age, recipient age is higher, more than 60, they have frail and their higher donor age is higher, and the MELD score, especially high MELD score patients, chances of complications are very high. So we have to select out these patients to do a simultaneous liver transplant and the metabolic surgeries. Regarding the endoscopic procedures, in post-transplant setting, the data is not much. Even especially the endoscopic balloon, we are at our center also we do, but usually some patients they complain of balloon intolerance, and after a balloon removal they will lead to rapid weight gain. Malabsorptive procedures in post-transplant setting you try to avoid, because they cause rapid weight loss and worsen the weight and glycemic control and high chance of malabsorption risk, and especially important the fluctuations in the TAC levels. As we see the recipient factors, there are the important donor factors also, especially because even in DDLT setting, even in LDLT setting, we see lots of donors with higher BMI. Even in DDLT setting, we are seeing the diabetic donors, especially the diabetic donors, they are usually elderly, they have higher BMI. Naturally, they have higher chances of graft steatosis. And these graft steatosis, they have prone for increased risk of IR injury. If you see the normal graft, they have minimal lymphocytic infiltration at the portal triad, but if in the steatotic graft, the hepatocyte will be surrounded by the neutrophilic infiltration, and that leads to the cytokine storm, increase interleukin 6, interleukin 10. The cytokines were measured at the just before reperfusion, at 1 hour after reperfusion, 1 day, and there was significantly higher cytokine storm in this group of patients. And even the steatotic grafts at the grade of steatosis increases, the increase of risk of graft dysfunction, especially of the primary non-function, and the survival decreases. And also there is a recent data from the US also, they have compared the diabetic donor versus non-diabetic donors. The diabetic donors have, the recipients who received the graft from the diabetic donor have poor long-term survival as compared to the non-diabetic donors. Why so recent? Because of this rising trend of the donors, especially in the US, in 1 in 10 donors are now becoming diabetic. So now the new strategy has come to especially defat these livers, and the role of machine perfusion has been come. Basically, it is a normothermic machine perfusion. It is you perfuse the graft at normal temperature with blood-based perfusate. The normothermic machine perfusion usually restores the cell metabolism, decreases the IR injury, and improves the graft function in the early transplant period. And how this, especially you can use combine the pharmacological agents like paroxysmal proliferator associated receptor agonist, carnitine, autophagy enhancer like carbamazepine and the froscolin. This leads to increase, they cause mitochondrial activation and causes beta oxidation. So increases the ATP content of the liver and increases the bile production. So we can assess the viability of the liver by looking at the production of the bile, the amount, the pH of the bile, the lactate content and the glucose content. The preclinical studies of the discarded livers had shown almost close to 40% reduction in the liver fat when the NMP has been performed along with the defatting agent for more than 6 hours as compared to the NMP alone. So this might be the in future maybe promising area to search out. Recently the DFAT trial is going on the UK and the results are awaited. Last but not the least, the genetic predisposition is also important. There are the protective genes also and the risk genes also, like patatin-like phospholipase domain analogs. Then transmembrane 6 and MBOT also is there. And this genetic polymorphism, either in heterogeneity or homozygosity, can lead to increased risk of post-transplant MASH recurrence or MASH. There are the protective genes also, like superoctet dismutase in the recipients, and if there are the combined, the genes are inherited from the donor recipient, it will have additive effect. Especially the TM transmembrane 6 family, they have lead to more causes more inflammation and advanced fibrosis in the graft. Recently we studied, this was one thesis given to the MCS student, that was Dr. Naren. He presented in the LTSI conference also. We choose the 45 pairs of genetically related and unrelated. In the 34 patients were genetically related and 11 patients were genetically unrelated. So we have seen the genetic and the metabolic profile and its impact on the post-transplant MASH. These patients were taken where we have minimum follow-up of more than 3 years post-transplant. And we have seen the genotypes, that is PNPLA3 and MBOT7 in this group. That was the GG risk was higher in the associated with the worsening of the steatosis, and it was more found in the recipient side. And also MBOT was it was CC was found in the MBOT. The CC variant was found with the lower grade of steatosis. Basically, the C allele is more common in Indian population, and we can combine to have this all the allelic risk score, so to find the exact risk of the post-transplant MASH recurrence or NAFLD. Also, we studied the diabetic and triglyceride, and the patient diabetes and triglyceride netted in the patient, the recipients in genetically related groups, which is the higher grade of steatosis. Also, the BMI was also higher as the grade of steatosis increased. So we did a regression analysis, and we found the model for predicting, and we combined both genetic model and metabolic model. The combined model had shown the best overall fit for highlighting the synergistic effect. So in both now, because our center is LDLT predominant center, we need to see both the metabolic and the genetic profile to predict the risk of post-transplant recurrence of the MAFLD or MASH. So how to go with the post-transplant setting? I think we should regularly follow up this patient initially, and we do routine checkups like sugar control, lipid profile, their blood pressures, and usually we see some risk flags, like they are developing higher BP, dyslipidemia, triglyceride more than 200, they're gaining rapid weight gain, especially 5 to 10 kg within 6 months. And they are developing signs and symptoms of obstructive sleep apnea. These are the worrisome signs, and you should act. Within first year, you try to avoid all surgical interventions because the graft is labile. So you try to stabilize the graft and bring the patient on immunosuppressant stable. You simultaneously advise them on lifestyle changes, diet and exercise. Try to avoid surgical interventions. 1 to 2 posterior transplant, still you can advise them the lifestyle changes, and you can add if the lifestyle changes and exercise are not, once the weight gain happens after 1 year, it is slightly becomes non-responsive to the lifestyle changes. You can add a metabolic pharmacotherapy, but we need more data on this. We can study it at ILBS also. Once they crosses the BMI more than 30, would develop comorbidities or higher BMI, we can evaluate these patients probably for the metabolic surgeries or either endoscopic or the minimal invasive group. But before going to surgical intervention, you need to ensure they have stable graft function and they are on the stable immunosuppression. And more than 2 year post transplant, metabolic surgeries usually they have their own stable immunosuppression, have stable graft function. They're usually safe in the more than 2 year post transplant LT. So in conclusion, most important is the early identification of the metabolic issues, and especially you should not treat a patient in the solidarity. You should take the colleague, your opinion from the hepatology, endocrine, especially the physiotherapy colleagues, and to have a multidisciplinary approach to address all the risk factors of the MASH in the post-transplant setting to achieve the improved overall outcomes. Thank you.